Hello, and welcome to the Clinical Care Options Infectious Disease podcast. I'm your host, Quentin Minson. Today's episode features content from an educational program titled Emerging Insights on Adverse Events During ART and Implications for Treatment. During this podcast, Dr. Joseph Eron from the University of North Carolina in Chapel Hill, North Carolina, and Dr. Darcy Wooten from UC San Diego Health in San Diego, California, discuss clinical insights on HIV antiretroviral therapy safety and tolerability. For more information on Dr. Eron and Dr. Wooten, and a link to the full online educational program, including downloadable slides specific to today's discussion, please visit the show notes for this episode. Now let's get started and hear what Dr. Eron and Dr. Wooten have to say about HIV ART safety and tolerability.
Thanks so much, and it's a pleasure to be here. Dr. Eron and I are going to be going over just a brief overview of some of the recent data on safety and tolerability related to antiretrovirals, but really hoping to spend the majority of the time having a discussion with you all and answering questions. So please feel free to enter those at any point. When we're thinking about choosing an antiretroviral regimen for a patient, of course, in addition to efficacy, we're also thinking and considering safety and tolerability issues. And you can see that weight gain has really sort of risen to the top of our minds when we're thinking about different regimens. And this is for a variety of reasons, but individuals with HIV are living longer. And so we're starting to see some of the conditions that occur as people get older, including weight gain and the associated metabolic complications like cardiovascular disease, diabetes, fatty liver disease, et cetera. And so these are going to play into our decision about antiretroviral therapy, whether we're starting a patient or thinking about switching. Other safety issues that might come up with certain medications, for example, if we're thinking about using TDF, bone and renal toxicity are important considerations. And then cardiovascular, neurologic, liver health are also important. And then if we have patients who are either pregnant or of childbearing potential, we might want to choose certain regimens over the other. And then in terms of tolerability, in addition to weight gain, which is of course both important to providers, but patients as well, there are also issues about complexity of the regimen, how many pills are in the regimen, how many times a day. We always need to do a good medication reconciliation to make sure that we're addressing any potential drug-drug interactions, talking with the patient and looking at the regimen to see if there's any food requirements. For patients that maybe are tired of taking a pill every day, we now have an alternative for them with long-acting injectable therapy, potentially. And then, of course, a very practical consideration in terms of financial coverage and the cost of medications. So let's talk about the updated guidelines in terms of recommended first-line antiretroviral therapy for most people with HIV. The DHHS guidelines were just updated a week ago or so. And what you'll notice here is that raltegravir, our first integrase inhibitor, has actually been removed as an initial regimen for most people. And this is because bictegravir, dolutegravir are highly efficacious and have a much higher barrier to resistance. And then also raltegravir doesn't come co-formulated the way that bictegravir and dolutegravir do. And so we might have some issues with pill burden there for certain individuals. But what you can see here in both the DHHS as well as the IAS USA guidelines is that all the regimens contain what we call a second generation integrase inhibitor, either dolutegravir or bictegravir. And then for the most part, two nukes, so either FTC and TAF or 3TC. And then the TAF or TDF could be either of those could be considered for regimens. And then the one difference that I'll point out is that the DHHS guidelines still recommend dolutegravir 3TC abacavir as one of the first-line regimens, assuming that the HLA-B 5701 test is negative in your patients. And then a newer regimen that's been added to both guidelines is dolutegravir 3TC. So this is unique because it's a two-drug regimen. But there's certain caveats to be aware of. So patients who have a baseline viral load greater than 500,000 or co-infection with hepatitis B would not be eligible for this regimen as initial therapy. You would also want to make sure you have a genotype back to make sure that there's no resistance mutations to particularly 3-TC with an M184V. So these are kind of the most recent guideline recommendations, but what you'll notice is not here is sort of what do we choose if we are concerned about weight gain, or if that's a particularly important component in thinking about a regimen for our patients. I'm going to turn it over to Dr. Eron to take us through some of the data related to weight gain.
Sure. So thanks, Darcy, Dr. Wooten. That was really terrific. So this is this is a very complete, I think, study that really is very helpful because it's based on randomized data. This was published by Paul Sachs in Clinical Infectious Diseases in the last calendar year. And what it does is it tries to help us understand what weight gain looks like by different classes of medication, specifically different drugs within the integrase class and the nucleoside class. So if you start all the way to the left of the slide, you can see that it seems pretty clear that people who start integrase-based therapy have a faster or greater increase in weight gain than with protease inhibitors or with NNRTI. We don't know for sure if this is due to the impact of the integrase inhibitors as a kind of positive weight gain, but that's what most people think, or whether there's some weight mitigating effects of at least of the NNRTI like efavirenz, which I think has some validity. When we look at the middle slide, you can see that the three of the integrase inhibitors are compared, and bictegravir and dolutegravir are associated with more weight gain than elvitegravir-Cobi. I think what this graph shows pretty clearly is that there really is very, very little difference in bictegravir and dolutegravir. And again, this came from randomized data comparing the two agents. At least some of the data is from a randomized comparison. So they are very, very similar. And then finally, all the way to the right-hand side of the slide, you can see the impact of a variety of nucleosides. And the contrast that I'd like to point out is really that between the yellow line, which is TDF, and the orange or reddish line, which is TAF. And there appears to be, I think, a pretty clear association of weight gain with TAF. I would be careful about whether we think that this weight gain is absolutely certainly caused by TAF. I think we have pretty good information that TDF has some weight suppressive effects, but the association is clear. Whether we can prove TAF as the cause, I think, is a little bit less certain. And those would be really good questions to ask, because I know Darcy and I would love to talk about that with you. On the next slide, this is looking at whether incident diabetes might be associated with integrase inhibitors. And these are claims data. So claims data are very useful because they're very powerful. So this is a market scan database from IBM with over 100,000 individuals in the data set. So that's really powerful. But on the other hand, these claims data have to rely on kind of outcomes that are coded, like ICD-9 or ICD-10 codes, or CPT codes, or medication coding. And this is looking at this very large data set, comparing people who started on an integrase inhibitor compared to people who started on non-integrase regimens. And if you again move to the right-hand side of the slide, it shows that integrase therapy was associated with approximately a 22% increased risk of acquiring or having a new onset diabetes or hyperglycemia during a 6-month period. And again, in the secondary analysis, which is obviously less powerful because there'll be fewer individuals, you can see this gradation. Dolutegravir having the greatest risk, and raltegravir basically having no risk. And this is adjusted for multiple factors, including age and male sex and comorbidities that are coded. I think that, again, a suggestion that one of the potential consequences of weight gain associated with the integrase inhibitors could be diabetes. Now, again, these data, I think, should be used as kind of hypothesis generating. We need other comparative studies to get to the bottom of how exactly there might be a cause between integrase and weight gain and potentially diabetes. But I think the data are quite important. And then on this slide, this is looking at the ADVANCE study and weight change and risk of cardiovascular disease and diabetes. The ADVANCE study, I'm sure many of our listeners know, was a randomized comparative trial between dolutegravir FTC TAF, dolutegravir FTC TDF, and then efavirenz FTC TDF, all done in South Africa. The difference in weight is along the top of the table, where you can see that there was on average a 10 kilogram weight gain with the dolutegravir FTC TAF, and a much smaller weight gain with efavirenz FTC TDF of 3.7 kilograms. And when we look at the estimated cardiovascular risk, interestingly, there was an increase with dolutegravir FTC TAF, but it was relatively modest, and while significantly higher when compared to the efavirenz arm, it was not really very, very high. On the other hand, if we look at the estimated 10-year risk of diabetes, and again, this is an estimate of risk, you can see again that the greatest increase in risk was related to dolutegravir FTC TAF, and maybe slightly surprisingly, efavirenz FTC TDF also had an increase in risk. So again, this weight gain may not be without consequence. So with weight gain and ART, I think guidelines now recognize weight gain as a common and a potentially severe AE associated with ART. I think many of us have had patients that have gained 15 kilos, even 20 kilos. And obviously that has substantial risk. But we don't really understand it. Looks like it's greater with integrase than with other classes, and greater increase with TAF compared to TDF, and greater with doravirine than efavirenz. But again, there may be some weight mitigation with TDF and efavirenz. And I think we still need clarification, and this is what the guidelines said, on distribution of weight gain, what risk is associated with it, and whether it's reversible, and what groups are at greater risk, which I think is a really important question. And we know that some groups are at greater risk than others.
Well, and I think I can take it from here. So that sort of wraps up kind of weight gain and thinking about it in terms of impact of integrase inhibitors as well as TAF versus TDF. I think the other kind of hot topic that we've been talking about for a while now is the association between integrase inhibitors and potential neurotube birth defects. And so we'll kind of go through some of the more recent data here and talk about sort of how the most recent data has really allowed us to update the guidelines. So everybody probably remembers back in May of 2018 in the SAPAMO study, which was a study in Botswana, looking at dolutegravir versus non-dolutegravir containing regimens for patients of childbearing potential. And there was an unplanned analysis that was done that sort of caused everybody to stop and take a look that there was actually what looked to be a higher risk of neural tube defects in women who were on dolutegravir at the time of conception compared to other regimens, specifically efavirenz. And this was pretty unexpected. And there were a lot of changes in clinical practice and guidelines in terms of, dolutegravir not being necessarily preferred for women of childbearing potential until this was sort of further sorted out. Additional data came in 2019, and while there was still an increased association with women who had been on dolutegravir at the time of conception and neural tube defects, this difference was much lower than what was originally identified. The denominator essentially getting bigger without many more cases of neural tube defects in babies in women who were on dolutegravir at the time of conception. And so this is kind of the most recent data that's been presented. And I'll sort of just highlight what's shown in the red box is that as we sort of followed this out, we found that really there's not a significantly increased risk for neural tube defects in women who conceive while receiving dolutegravir compared to the other regimens. And when you compare it to efavirenz, the risk is really just slightly higher. And so this was, I think, reassuring to a lot of people because dolutegravir is widely used and is highly effective, and led to sort of some of the most recent DHHS guideline updates and other guideline updates in terms of can we use dolutegravir at the time of conception, because the guidelines had kind of gone back on this when it was still a big question mark. And so the most recent guidelines kind of put this to rest and, say that it is now, again, dolutegravir is a preferred agent in the regimen for people of childbearing potential. Of course, you need to, sort of have a one-on-one conversation with patients, sort of reviewing some of the data and the risks and sort of individual preferences, but it's nice to sort of reassuringly be able to use this in this patient population. So this was, I think, a nice update following out that data. So I think we'll sort of wrap up here. We've covered a number of these safety and tolerability considerations, really focusing on weight gain, but also sort of in specific patient populations in terms of childbearing potential and the role of integrase inhibitors. We're going to do an outcomes case, and then we'll turn it over to Q&A. So here is our outcomes case. You're providing care for a 54-year-old African-American woman who's newly diagnosed with HIV. CD4 cell count is 355, viral load 655,000, no resistance-associated mutations in baseline genotype. She is HLA-B5701 negative, hepatitis B immune, and all of her other labs are within normal limits. Her BMI is elevated at 28, and she does have a family history of diabetes. So we'll come to our poll question and vote. So which of the following would you recommend as an appropriate first-line regimen for this patient if you're really trying to minimize the likelihood that it will impact her weight or cause any weight gain? So go ahead and answer the poll. All right, great. And it looks like the majority of people got the correct answer. So B, dolutegravir FTC TDF is the correct answer. All of these are first-line regimens that could be used in patients. As we sort of reviewed some of that weight data, especially potentially the role that TDF might be sort of weight neutral or weight mitigating, that would probably be of the options listed here, really the one least likely to potentially cause weight gain. Although we should always be aware and counsel our patients that any patient starting therapy for the first time, there is an expected sort of return to health degree of weight gain that we should counsel patients to anticipate. But with this regimen in particular, I think really nicely displayed in the data that Joe showed on the advanced trial, TAF containing regimens as well as that additional factor of a second generation integrase inhibitor with dolutegravir seem to be much more associated with weight gain compared to the dolutegravir FTC TDF regimen. And then, I think we'll probably in the Q&A talk about the option of dolutegravir 3TC. If I'm remembering her viral load correctly, it was probably a little bit too high to be appropriate to use this regimen, but we might get into in the Q&A whether or not dolutegravir 3TC, if we could have used it for this patient, if that might have an impact on weight or not. So I think we'll stop there and move to questions.
Yeah, so Darcy Gale asked a really a question, beautiful, that follows up on this. She asked, what about considering an NNRTI-based regimen in this case, since she has this risk of weight gain and diabetes in addition? So what do you think about that?
I think it's a great question, and I don't know that I know the answer to it or that there's necessarily data, but it is something that I'm thinking about with my patients when I'm really concerned about weight gain and metabolic complications as well as my patients. And the thing that probably the NNRTI that I'm thinking about is doravirine. Now, doravirine isn't, one of the preferred regimens for most patients. And the other thing to remember about doravirine is that it, does have probably a lower barrier to resistance compared to bictegravir and dolutegravir. So that's something that weighs into my decision making. It doesn't come co-formulated with TAF. It does come co-formulated with lamivudine and TDF. So if there's somebody who's got osteoporosis or renal insufficiency where I'd want to avoid TDF, I'm not going to be able to use it at least co-formulated. But it's something that I'm thinking about doing, and I'm hoping that we'll get a little bit more data in terms of whether or not that's the right decision with respect to weight gain. I'm curious to hear your thoughts too, Joe.
Yeah, I would pretty much offer the same answer. I think we don't know enough about who gains weight when we start them on a second generation integrase and a TAF-based regimen. Though again, our test case of a Black woman, especially if that person already has some risk for obesity, they're already obese or at least overweight, that would be a really high risk person. I do think we know, for example, when doravirine was compared to efavirenz head to head, there was more weight gain with doravirine than with efavirenz, given this idea that efavirenz might be weight mitigating. I'm not quite ready to go there. Though in this woman, this case, I think I would choose perhaps a TDF-based regimen, especially if I knew her renal function was completely normal. We know that if you avoid a booster with TDF, the risk of renal consequences is actually quite small, and she may have less risk based on her background for osteoporosis than other people. So I think. I would probably still stick with a second generation integrase. We do know, if you fail a first generation NNRTI, then a second generation integrase is likely to salvage that. So you don't lose a lot if the doravirine works. But I would still probably stick with a second generation NNRTI integrase with probably TDF as we selected in this particular case, at least most people selected.
Yeah. Well, now what about this question? Let's say that this patient had a lower viral load, didn't have any resistance mutations and didn't have chronic hepatitis B. And so in theory would be eligible for dolutegravir 3TC. Would that impact weight at all? What are your thoughts about that? And would that be a regimen?
Yeah, that's a great question. In fact, it came up in clinic today, actually. Kind of coincidentally. We do know that if you compare dolutegravir FTC TDF and dolutegravir TAF, that's what we saw. That was the direct randomized comparison in the Gemini study. There was more weight gain with dolutegravir and 3TC. So that goes to the weight mitigating effect of TDF. I think it would probably have less impact than dolutegravir TAF FTC or bictegravir TAF FTC. So I think it would be worth considering. I agree. I've not used a lot of 2-drug therapy in first line, but with a lower viral load, and if you have resistance at baseline, and they don't have hepatitis B, I think it's a very reasonable choice. And in fact, that's what we're going to do today in clinic, and it'll be interesting to see what happens to this particular patient that we saw today. So good point. We have a question from Rachel. This is a good one, and I like this question too. She asks, how do you counsel patients with isolated hepatitis B core antibody when switching off tenofovir-based ART to an NNRTI sparing regimen such as dolutegravir and rilpivirine? A tough question, I think.
That's a great question. I will take a stab at it and probably get it absolutely wrong, and then you can come back and correct me. But I think this is a really tough case. And I think one of the things I try to think through is, do I think this person's isolated core antibody is just a false positive? Do I think that, they do have risk factors for, having been infected with hepatitis B and then they lost their surface antibody? Interestingly, an internal medicine resident at my program here did a study looking at hepatitis B vaccination practices and hepatitis B monitoring by HIV providers. And the consensus for this exact scenario was basically split completely 25%, 25% in terms of, how to approach it, just to speak to the point that A, the guidelines aren't very clear on what to do, and then B, everybody's doing sort of something different in practice. So I think my first step would be to think, do I think this person could actually have, chronic hepatitis B? You might check a hepatitis B DNA to see, maybe they have a colt infection, and then because we worry about the risk of stopping a tenofovir containing regimen if somebody has chronic hepatitis B infection. But I'm curious to know what your thoughts are, Joe.
Yeah, boy, first do no harm. So for sure, I would make sure that they were, antigen negative and DNA negative. And then, we've argued about whether this person should be vaccinated or not. And I don't know what you would do at your center. And I know Raj Gandhi has looked at this in the distant past, but I would be tempted to actually vaccinate this person, which, people may, I think that has little harm, and then reconsider. I just, I would have to have a pretty strong reason to take this person off a tenofovir containing regimen. That would be my approach. I have, again, this is really strange. I saw one of my patients today who was surface antibody positive. I never checked a core. He was antigen negative, so antibody antigen negative. He had tremendous difficulty with nucleosides. I took him off, and that patient had a huge increase in hepatitis B DNA, which I didn't check before I did it, up to 54 million. So I am very sensitive to the fact that I think those 2-drug regimens, which are great, convenient, and safe, I'm very cognizant of paying attention to hepatitis B status.
Yeah, definitely. I also just generally, I'm always looking for a reason to get people off of rilpivirine. I've just run into issues in terms of drug-drug interactions and the food requirements that have been problematic for some of my patients. So I'll just leave that there. But let's turn to another question from Mark. So in this new regimen with cabotegravir and rilpivirine, the long-acting injectable therapy, what are your thoughts, Joe, and what does some of the data show in terms of impact on weight gain? And could this be a more sort of weight neutral regimen for people? What do we know there?
Yeah, it's interesting. I know best about cabotegravir, and I'm a little less sure about the combination. So you may know more. What we know about cabotegravir, because it's been studied in HIV uninfected people in the setting of pre-exposure prophylaxis, that we know that there's kind of a modest weight gain with dolutegravir that's probably consistent with what happens in people in life. We unfortunately, all of us tend to gain weight very modestly, a kilogram or less per year, but a pound or two per year. And that's what we saw in the PrEP studies. So we haven't heard a whole bunch about cardiovascular risks with abacavir recently. Should we ever use abacavir as first-line therapy? There's kind of a disagreement between the DHHS guidelines and the ISUSA guidelines. Where do you sit?
I was quote unquote raised by the DHHS guidelines, but I have to sort of say that I tend towards the ISUSA guidelines for a couple of reasons with respect to not having dolutegravir 3TC abacavir as one of the preferred regimens for most people. So of course you have to have the HLA-B 5701 test result back before you start that regimen. And we're doing a lot of rapid start, same day starts now. And so we don't always have that information. And I am concerned about the cardiovascular risk. The data is somewhat mixed with, some studies showing an increased risk of cardiovascular disease associated with abacavir, while others, haven't shown that. All the studies are imperfect, but I think, all other things being equal, if you can find a regimen that doesn't have that associated toxicity, I would tend to sort of use an alternative regimen than using one with abacavir. So that, and with the weight gain that we're seeing in association with integrase, the second generation integrase inhibitors, and kind of seeing patients with HIV living longer and kind of having some of these metabolic complications occur, I'm trying to, I never start somebody, I can't remember the last time I started somebody on an abacavir containing regimen. And then for patients who are already on it, I'm looking to see if they're appropriate candidates to actually switch to something else because of that cardiovascular risk. So that's kind of where I'm at in my practice. Are you doing something similar?
Yes, very similar. I would argue that if you had someone that you were sure were hepatitis B immune or hepatitis B negative, and they didn't have a viral load greater than 500,000, what would be the advantage of dolutegravir abacavir 3TC over dolutegravir 3TC alone? So I would argue that really the scenario where you would want to use dolutegravir abacavir 3TC as a start of therapy is really a very, very limited scenario. So I do think that it's really not common for me, and I have a hard time coming up with a scenario where I would be using abacavir, to be honest with you.
Well, there's another question sort of talking about maybe side effects and toxicities that maybe we've been talking less about, but I think still come up on occasion. What would you do with a patient who's maybe on a dolutegravir containing regimen, but then, after being on it for 2 or 3 months, they start to develop, maybe a little bit of sleep disturbance and maybe some increased anxiety? What would you do? Would you attribute to the dolutegravir? Would you change? What's been your experience there?
Yeah, that's a really, it was a little bit more common before. I don't know what's exactly happened where, it was really quite a bit of discussion. It's been kind of replaced by weight gain. I have seen it. I actually saw it with raltegravir, to be honest, in a few people, way back when. I do think integrase inhibitors occasionally have effect on anxiety and then sleep. So I think that there is it is possible that that's the cause, and I would kind of look into make sure that there aren't other causes for anxiety. People have a lot of stress, especially at this time and with the COVID. But I do think that it's possible, and that is a scenario where I might consider, especially if the person was well suppressed, an integrase-based therapy, for example. I do know I've had other providers tell me that, well, sometimes just switching among the integrase inhibitors actually work. So going from dolutegravir to bictegravir, though I feel like you can see it with either. So I would take it seriously that it could be related to the dolutegravir, especially if I don't find another source. So I think that's important. So I do want to get back because I'm conscious of the time. I have open Chloe Orkin's New England Journal paper of the FLAIR study. And this is a direct quote from the paper. At week 48, the median weight gain from baseline was 1.3 kilograms in the long-acting therapy group and 1.5 kilograms in the oral therapy group. Remember, in the oral therapy group in that study, participants were on dolutegravir, abacavir, 3TC. So not TAF, but dolutegravir, abacavir, 3TC. And abacavir is kind of, at least in the data from Paul Sachs, is kind of in the middle between TDF and TAF. So contrary to my guess, which was off, there doesn't really appear to be much in the way of substantial weight gain with cabotegravir ropivirine. And the interquartile range was loss of a kilo up to a gain of 5 kilos. So there is less than a kilo up to a gain of 3.9 kilos. So probably almost 10 pounds, but probably in a return to health kind of thing. So that, I think that's, a good question that one might ask. Maybe that is a strategy for someone where you feel there's a high likelihood of weight gain, maybe suppressing initially on oral therapy and then moving to cabotegravir ropivirine could be considered. I wasn't aware of that, and I appreciate Mark, our questioner, on bringing that issue to our attention. That was really great. Thank you.
And just to maybe wrap up the discussion on the long-acting cabotegravir ropivirine injectable therapy, any important drug-drug interactions that we need to remember with these?
Yeah, the big advantage is what you brought up, of course, which is we don't have to worry about the proton pump issue if the ropivirine is injected. Now, there is that 4-week lead-in where it is important. But after that, you obviously don't have that issue with an injectable. And the other thing would be that there are some studies of direct to inject where you start with the injectable without that lead-in. And I think we'll hear more about that. That is not in the package insert currently, so I'm not recommending it, but I know people are studying it. But I think sometimes with injectables, we forget about drug interactions, and one has to be very careful about agents that are inducing agents, right? So agents like rifampin, rifabutin, carbamazepine, dilantin. So those agents will increase the clearance of both cabotegravir and ropivirine. And even though the patient isn't taking those pills, and depending on how your medication system is set up in your electronic medical record, when someone's scanning it, they might not pick up that this person, 3 weeks ago got cabotegravir ropivirine. So we have to be careful about that. That's the main one that comes to mind for me, are strong inducers. And you'd probably put St. John's wort right in there too. So we do have to be careful to keep that top of mind when we go to the long-acting injectable for treatment.
Yeah, but I think, the nice thing is, right, overall, there's not a ton of drug-drug interactions with that regimen or really with most of our preferred first-line regimen. So that's Absolutely. Great. There's one follow-up question about sleep disturbance and bictegravir, and if we've seen any data on that. I haven't seen any data. I've had 1 or 2 patients where I sort of chalked it up to that, but it's been very minimal. I don't know if you've seen data on that.
Yeah, I don't know of data. There probably are some, but I would say that in my experience, I've seen it. There are very, very similar drugs, dolutegravir and bictegravir. So I would be kind of shocked. I mean, the thing that's amazing is that how, the weight gain that was seen in the in that nice paper from Paul Sachs. It's like virtually overlapping between dolutegravir and bictegravir. So I don't think there's anything particularly special about the adverse effects of those two agents. I think they're very similar and overlapping. And to be fair, they're very, very good. They're very, very safe medicines, and they're extremely well tolerated, both of them. And the fact that you're much younger than me, but if you'd told me in the early 90s that I would be having a discussion in 2021 about the risks of weight gain and HIV, I would have said, stop smoking whatever you're smoking and let's get back to reality. So it's really a very different world.
All right. Well, I think we're just about at time. That was a great discussion. I really appreciate all of the questions that you sent in.
Great. It was a pleasure speaking with you.
Great. Thank you very much to Dr. Eron and Dr. Wooten, and thanks to listeners for joining in. As a reminder, to view the full educational program, Emerging Insights on Adverse Events During ART and Implications for Treatment on the Clinical Care Options website, click on the link in the show notes. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you and have a wonderful day.